everybody. So here's the answer to today's quiz. So the first question is basically just a photograph. 50-year-old female presenting with multiple erythematous scaly guttate plaques over the legs, back, abdomen since 1.5 years. No scalp lesions. As you can see here, some look slightly sort of erythematous scaly plaques, small guttate lesions here, some on the anterior shin, and you can see on the legs they look more lichenified, eczematous. Some maybe slightly lichenoid here, or maybe just scaly. So you can see some sort of psoriasiform plaques here on the elbows as well. No scalp lesions. This is on the shoulder and this is on the legs. Not many lesions on the knee. So that's the clinical. This is where the biopsy was taken from. So the low power histological image basically shows regular psoriasiform acanthosis. When I say psoriasiform, there is sort of clubbing of the reti ridges. You can see here, elongated reti ridges, some clubbing. Parakeratosis, you can see here, you can make it out. There is not much suprapapillary plate thinning, to be honest. Suprapapillary plate thinning one would expect if it's it's in psoriasis, but not much of that is evident. Here you can see that the epidermal thickness near the papillae and near the reti ridges is almost the same. So if there's suprapapillary plate thinning, they should go even up. But having said that, there is hypogranulosis. You can see here that the granular layer is completely absent. Here it's more or less normal, here it's absent. So wherever there is parakeratosis, the granular layer seems to be less. There's no spongiosis. There is inflammation within the dermal papillae with a few dilated blood vessels. But what is interesting is that there is lichenoid sort of a vacuolar interface change. You can see that the epidermis here, the basal layer is almost replaced by this sort of vacuolation. You can make out some vacuolation here as well. And there are melanophages too. You can make out the melanin incontinence here. So it's got a confusing picture here. You can see this in higher power, a small normal mitotic figure here in case you missed it. So what are we dealing with? So there is vacuolar interface change. Compact hyperkeratosis is absent, but there is parakeratosis, there is melanin incontinence, there is hypogranulosis, not hyper. Clubbing of reti ridges is present, and this is predominantly I wouldn't say a lichenoid. This is predominantly actually comes under psoriasiform dermatitis with some mild lichenoid change. This is confusing, but you need to look at the overall picture. Why have I called this not a lichenoid dermatitis? Because the predominant picture is not that of a lichenoid dermatitis. Lichenoid dermatitis, you don't see elongated reti ridges. You see more flattening of the reti ridges. Okay, and lichenoid dermatitis, the lichenoid inflammation is much more prominent. Here it's more focal, only present around a few areas. Here it's hardly present. Okay, so this is predominantly a psoriasiform dermatitis with focal vacuolar interface change. That is what this is. There is no spongiosis. So given the clinical diagnosis, the best fit here is lichen planus is excluded because in lichen planus you'd expect a band-like lichenoid inflammation, which is absent here. Mycosis fungoides, we'd expect epidermotropism, ATP of lymphocytes, Porträt's microabscess, etc. Though there may be psoriasiform acanthosis in mycosis fungoides, the rest are absent. Discoid eczema, again predominantly a spongiotic dermatitis with lichenification, no spongiosis here. So the answer here is in fact psoriasis. It is neither lichen planus nor mycosis fungoides nor discoid eczema. So often in clinical practice, the diagnosis is not that straightforward, and that's the reason I put this case. Sometimes you may have a mixture of features, and therefore we as pathologists insist on clinico-pathological correlation. Though this is a commonly laughed at statement in histological reports, unless you correlate clinically and histopathologically, you cannot make a diagnosis in most cases. If I was given just this histology without any clinical, if I put parapsoriasis in here in the differential diagnosis, it would have become very difficult. Parapsoriasis is also a possibility, but one would expect a bit more spongios in parapsoriasis. And clinically, I don't think this quite fits parapsoriasis. But having said that, parapsoriasis can is in the differential, clinical differential. I haven't put it here because it is confusing. I think initially this patient deserves treatment as psoriasis. If the lesion evolves into something else, then we can think of parapsoriasis. But at this point of time, psoriasis is still the best diagnosis here. Thank you.